A'udhu billahi minash shaitani rajim. Bismillahir Rahmanir Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to the third edition of the Medical Matters that we're hosting here. And again, as previously, I have the honor of hosting Samina Parkar, who is a specialist dermatologist, and I want to say thank you for taking time out on a really busy social life and actually coming to enlighten us on certain topics. And today we'll cover another important one in our society.
Wa alaikum salam wa rahmatullahi wa barakatuh, and shukran so much for having me once again.
No, it's an absolute pleasure. I mean, you're absolutely colorful today. But unfortunately, the topic that we're going to talk about today is not as colorful. It tends to be a bit of a problem for especially teenagers. So let's start off with the topic itself, and it's acne.
Yes.
What exactly is acne?
So acne, and the commonest type of acne is actually called acne vulgaris, and vulgaris in Latin just means common, and it's one of the most common skin disorders that affect patients that are aged between 12 to 24 years. Around 85% of patients around 12 to 24 years of age that it does affect, and it's a inflammatory skin disorder that affects the pilosebaceous unit of the skin. So by pilosebaceous unit, I mean a hair follicle, a hair shaft, and every hair follicle is attached to an oil gland. So those three combined are referred to as the pilosebaceous unit.
So it's basically hair follicles that are affected mostly on the skin.
Yes.
Now, you mentioned the age group, but
Yes.
I've often had kids in general practice, babies actually, just born. They come into the practice, mommy comes and says, my baby's got acne.
Yeah.
Baby's a couple of weeks old. Do we consider that to be acne?
So acne in neonates is not something that's uncommon. So
Right.
around 25% of neonates do get acne, and I mean it's a self-limiting skin condition that resolves on its own. But of course, we always taught in medicine that common things occur commonly. So when you do get confronted with a baby or a child, for that matter, that has pimples on their face or what parents perceive to be acne, there is of course a list of differential diagnosis that we consider. And the first thing that one can consider are infectious causes. So, you can have impetigo or bullous impetigo that can look like, pus pimples. And then we get fungal infections such as candida. We can also get herpes simplex virus. And then of course scabies also affects children quite commonly. And then we have certain transient disorders that are also, not life-threatening, they're self-limiting. And there's neonatal cephalic pustulosis, there's erythema toxicum neonatorum. And then if we look at the variants of acne, or acne specifically in pediatric patients, as Dr. Parker mentioned, it is present, and I would say that if it's neonatal acne, it's usually in a baby, so from birth to 1 month of age, and then you get infantile acne, which is from 1 month to a year age, and then you get mid-childhood acne, which is from 1 year to 6 years of age, and then you get early adolescent acne, which is from about 6 to 11 or 7 to 11 years of age.
But that's all self-limiting mostly.
Yes.
So if a parent sees what they perceive to be acne, child is relatively well, feeds well, plays well, interacts well,
Yes.
just has these pimples, we consider it to be just a transient thing.
Yes,
But
especially in babies.
Yes, if it's transient, what exactly? Time is differs for different people. For
Of
me,
course.
1 day is a lot. For someone else, a month is not a big issue. So
Yeah.
if we say transient, how long do we say in small babies? I mean, a month, a couple of months old.
So it can last anything from 2 weeks to a month.
Okay, and do we
Okay.
treat it or do we just watch it?
So the best thing is always to reassure and counsel the parents and tell them that, it's something that's self-limiting and will resolve on its own. And the other things that you can use are topical. So you can always use an antibacterial wash. And I don't think it's necessary to treat it with a course of antibiotics, because you know that it's going to have a self-limiting course.
Okay, excellent. Now, you've already mentioned that it's the younger age groups, teenagers and so forth, that suffer from acne. Why exactly is it in that age group predominantly? But we do obviously know that it's in older people as well.
Yes,
but why
definitely.
predominantly in the teenage group?
Yeah, or
And
pubertal
yeah.
range. Yes, so it's because of of course, when we reach puberty, that's when our hormones peak, or
Right.
are at their peak. And we have a particular hormone in our blood called testosterone. And testosterone and dihydrotestosterone are the main driving force behind acne, because it's the testosterone that stimulates, it all starts with the testosterone stimulating the oil glands to enlarge and produce more sebum. So it's that androgenic stimulation that starts the whole, cycle of acne.
Okay, now that you've mentioned the cycle of acne, what happens? So we've spoken about the hair follicle, we've spoken about the androgen hormones,
Yes.
and we've spoken about the oil production.
Yes.
So what happens? I mean, why does it affect certain people and not others? And even in families, we see just one person with severe acne and the siblings will be quite fine without any issues.
Yeah, for sure. So there is a familial predisposition, and it tends, if one person has had severe acne in the family, it can affect their children as well. And then the causes of acne are, so firstly you have the androgenic stimulation of the oil gland, and you have testosterone and dihydrotestosterone, as I said, that stimulates the oil glands to become larger and to produce more sebum. Then the second problem or cause in acne is the fact that, we all shed skin on a daily basis, and that's called keratinization. And you have the same thing happening at the level of the hair follicle. Okay, but in acne, the problem is that you have follicular hyperkeratinization. So there's a lot more keratin being shed. And if you can just imagine a skin opening or a pore with hyperkeratinization inside the pore, you have all these skin cells that you've shed off that are not really moving anywhere. They're clumping up together and stuck together thanks to all the oil that's present in the pore coming from the oil gland.
Right.
Of course, it's going to form a blockage or a plug, and that's the start of acne, and we call that a blackhead or a whitehead. And because that oil has nowhere else to go, it causes that pore to swell, or that follicular opening to enlarge and swell up, and that's when you get the red bumps. Eventually the swelling gets so bad that it actually ruptures the hair follicle, and then of course that forms or causes an inflammatory response, and you get a lot of pus forming in that area. And the deeper the inflammation, then you'd get the nodules and cysts forming, those indurated painful lesions that we see on patients' faces.
Yeah. You mentioned androgens, and when we think androgens, we normally think male testosterone, for
Yes.
example, which
Yes.
tends to be higher in males than in females.
Yes.
So does it necessarily affect more males than females, or is it an equal proportion who get
So it's
acne?
more or less an equal proportion. It's only after, in patients that are in their 30s that it tends to be more common in females. So you have 1 in 3 females that are affected after the age of 30, and 1 in 5 males that are affected after the age of 30.
But prior to that, in the teenage years and pubertal years, it tends to be relatively equal.
It's relatively equal, except for acne conglobata and acne fulminans, which is more common in males.
And why is that so? Just explain that. Fulminans
Gee.
sounds quite quite serious.
No problem. So acne conglobata is severe nodulocystic acne, and they can get it anywhere on the face. They can even get it on the neck, on the chest, and the back area. And this is usually adolescent males, as I said. And this is without systemic manifestations. By that I mean a fever, joint pains, osteolytic bone lesions on the sternal area. And then acne fulminans is acne conglobata, but with systemic manifestations. So it's also severe nodulocystic acne, but
Right.
with systemic manifestations, like the ones I mentioned before. And these patients are usually quite ill, sometimes even need admission into hospital. They need prednisones to calm the acne down for a couple of weeks prior to isotretinoin treatment.
Okay, that's one topic we must come to. So, but we'll
Sure.
cross that bridge when we get there.
Sure.
Now, beauty is in the eye of the beholder, but so acne seems to be. I've had especially young girls going to a matric ball, for example, and saying, I need to get rid of this pimple. And I ask her, where is it? Doctor, can't you see it? I mean, it's like a watermelon, the size of it. And I literally need a microscope to see it. So to see what it looks like, it's that small. So,
Yes.
so from a clinical point of view, how do we classify it? I mean, do we take what the person says, or is there actually a specific classification that we can say this is good, this is bad, this is severe, and so forth?
Okay, so there is a grading system that all of us use in practice, and I'll explain it. So there are 4 grades, and grade 1 is when you have blackheads and whiteheads only.
Okay, what's the difference between the two, blackheads and whiteheads?
Sure. So the whiteheads are usually skin-colored bumps or papules, as we refer to them, and they don't usually have a follicular opening, so they're blind-ended. Okay. And then your blackheads are, also bumps, exactly like the whitehead, but they have a follicular opening, a dilated follicular opening, and it's usually shed keratin that's in there. There's melanin pigment in there, which gives it its black color, and also oils that are inside that have been oxidized.
Exposed to these outside?
Yes.
Okay,
so
basically the blackheads has been exposed to the outside atmosphere?
Yes.
More or less, okay.
Yes,
Got
and
that
it's got
right.
a follicular
Okay.
opening, and I mean
Right.
it's black, so it's called a blackhead. Yeah.
Okay.
Yeah.
Okay, sorry, getting back, so we're talking of the classifications?
Sure,
so
sure. So there are
grade
4
1.
grades of acne, and grade 1 is when you have whiteheads and blackheads, so open and closed comedones, and that's just the scientific term for a blackhead or a whitehead. And then grade 2 is when you have open and closed comedones plus inflammatory papules, which are the red bumps that you see on the skin. Okay, and then grade 3 is when you have comedones, papules, and pustules. Okay.
That's pus-filled
Yes. So,
pimples.
so those are blisters, but the fluid content, or the content of the blister is not clear fluid, it's pus, it's purulent fluid. And then grade 4 is when you have nodules and cysts. So those are the 4 grades. And the important thing to remember is that whenever you're grading acne, obviously just bear in mind that it can still be subjective. I mean, I might say I can see a pustule, and you might say I don't see any pus, I see a papule.
Right.
So it is still subjective. I would say that is one downside. The second downside is that often people, grade it according to the number of lesions, but that shouldn't be done. You should rather grade it according to the type of lesion, and that's exactly what I've described, 1 to 4. And then I would say the last shortcoming of this grading system is the fact that it doesn't take scarring into account, and that's the main aim of treatment of acne, is to prevent the scarring, because the longer the duration of the inflammation, the greater the chances of having significant scarring afterwards.
And scarring is permanent. Scarring is permanent, right?
It's irreversible.
Now, we've mentioned blockage and so forth of the oil of the hair follicles.
Yes.
Does cleanliness have anything to do with it? I mean, there's often the accusation of youngsters, especially, that they're not cleaning their skin properly, they're not cleaning it adequately, or they're not cleaning it with the correct type of soaps, for
Cleanser.
example.
Sure.
Is there a relationship between cleanliness and diet, if I may have, put those two bunches
no
two
problem.
together?
So hygiene, fortunately, I mean, obviously a good hygiene can only be good for acne.
Right.
So I would say that, one should incorporate cleansing your face at least once or twice a day. In acne, we actually encourage twice a day, as opposed to eczema, for example, where we say once a day is ample.
Right.
But it's fortunately not hygiene related. If I may say, I don't want to say that it is related to hygiene, because what often happens, patients think that it is a hygiene problem, and then they end up over cleansing the skin, over exfoliating, which can actually cause more harm than do good, because we know that the skin barrier in acne is also impaired. So we don't want to over cleanse or cleanse too harshly. And often what happens is the fact that there's grease present on the skin makes patients want to over cleanse. But you can have greasy skin and still have skin that is dehydrated. So I don't want to say that it's hygiene related, but of course if you've had, if you've exercised, you've been sweating all day, you've been outdoors in dust, in pollen, if you're using makeup or any occlusive products, so I mean products that block your pores, of course, those are going to contribute or aggravate your acne.
Right, yeah.
And you have to cleanse.
No, absolutely. Thanks for elaborating.
Sure, and then whereas diet is concerned, the only two things that have been implicated, of course diet is still a very controversial topic in acne, but two things that have been implicated where there is evidence, that it definitely has a positive association with worsening of acne would be skimmed milk. And then the second thing is a high glycemic index diet. So anything that is very rich in sugars, fats, you want to rather avoid.
Okay, I'm surprised that this has been shown in detailed studies, but skim milk, what would be the mechanism? Is it understood as such?
I'm also not sure, doctor.
Okay.
I'll be very honest. But it's your low-fat milks. Yes,
our patients read everything,
yes.
So they come well prepared. So I've also been asked that. I thought I'd get the answer from you, but we both have to
next
try
episode.
And find out. Yes. And the second thing is the high glycemic index foods. Is it purely because of bacteria that's on the skin, like glycemic?
Yeah. So the fact that it increases your insulin and it can lead to insulin resistance.
And insulin resistance is on its own associated with acne, isn't it?
Definitely.
Okay.
Yeah.
Okay, so we've talked of cleanliness. How exactly would you ask your patients to clean their skin?
Sure. So I know
before they even are graded. I mean, someone with acne, whether it's grade 1 or 4, how would you advise them to you said up to twice a day, but how would you advise them to clean it?
Sure.
What to do?
So what I normally tell them is to obviously cleanse twice a day. And what they need to use is, so depending on what their skin is, if it's on the greasy side, then I normally tell them to use face washes that have a bit of salicylic acid in them, which can break down the lipids, of course, or the oils in the skin. And then, of course, if they've got a more inflammatory type of acne, then I tell them to use a face wash that has benzoyl peroxide in it. And that's because, so we were discussing the cause of acne earlier, and the causes were, of course, the androgenic stimulation of the oil glands. Then we have hyperkeratinization at the level of the hair follicle. And then the third problem is a bacteria that's found on all of our skin, and it's part of our normal flora. It's called Cutibacterium acne.
Right.
And what Cutibacterium acne does is it loves to feast on the oils that are within your pore. So it loves the free fatty acids. So that, of course, triggers more inflammation and takes advantage of all the oil that's present. So that's why benzoyl peroxide, being an antibacterial, can then tackle the Cutibacterium acne. And then, like I said, if it's greasy skin, then I tell them to go for more, salicylic acid-based face wash. Yeah, but the important thing is, just to end off that, you want to go with something gentle, not too harsh. Don't over exfoliate the skin. So twice or thrice a week is more than enough.
Okay.
Yeah.
And often the patients are advised to pat the skin dry rather, and not rub it.
Yeah.
Is there some evidence for that? Or
so patting the skin dry still allows some of the moisture to remain on the skin. Right. And of course, I think that's more relevant for eczema as opposed to acne, because what happens in eczema is when you rub your skin dry, you're actually activating the itch-scratch cycle, which is why they say you need to gently pat it dry.
Okay, no, that's right. So now if you look at that, we're looking at probably grade 1 now. So if it's a grade 2 type of patient and who's got acne, what would you advise? Cleansing? What's the next step in the in the algorithm or this stepwise approach that you have?
Sure. So we've discussed the cleanser. The next thing you want on board is a topical retinoid. And a topical retinoid is the backbone of acne treatment, irrespective of which grade it is. I mean a retinoid, not a topical retinoid. So for a grade 2 acne, which is your comedos and inflammatory papules, you want to have the cleanser, so either benzoyl peroxide one or something containing salicylic acid. And then you want to get a topical retinoid on board, and that's usually for the more superficial inflammatory papules. If you see that it's grade 2 and it looks like those deep inflamed papules, and then and the skin is a bit on the greasy side, then you would want to add an oral antibiotic, and that's where your tetracyclines come in.
And are there any age groups where you would use tetracyclines and others that you would not use it?
Sure. So patients that are aged 8 and above, we use tetracyclines. Obviously in children we don't use tetracyclines, we opt for erythromycin, and the same for pregnant patients. It's because it would affect their skeletal system or their growth, and then also the dentition.
Okay, and if they go on to the antibiotics, say tetracycline, for how long do they have to be on it?
Sure. So it's usually a 3-month course, and it's a daily dose of, let's say if it's doxycycline, then it's 100 milligrams per day for 3 months.
Right.
And then if it's tetralysyl, it would be 250 milligrams daily for 3 months.
Does it cure the acne? Does it control it? Or what does it do when we refer specifically
so that
to
combination
the
of the tetracycline plus, let's say, epidural, which is a combination of benzoyl peroxide and a topical retinoid called adapalene. That combination together, I think it's postulated that around 90% of patients clear completely. But there is obviously that other 10% that might still need the next step in the algorithm.
Right. So if, would you, for example, if someone who's got grade 3, would you start with the tetracyclines, or would you go to something more potent? Or if it's someone, for example, presenting for the first time,
Yes.
with severe nodular ones, would you consider the tetracyclines first, or would you then go for something more potent?
Sure. So if it's nodular acne, that's grade 4.
Yeah.
So any nodules or cysts, then we opt for isotretinoin because it's considered as grade 4, and that's severe acne. If it's grade 3, let's say there are inflammatory papules, comedos, and then pustules present, then we obviously we have to sit down and have a discussion with the patient, and then mutually agree what is best for the patient. And usually I do give patients a trial of the oral antibiotic plus the combination of benzoyl peroxide and the topical retin, and a lot of patients do actually come back with their acne clear, very happy. And of course there is that minority that comes back and the acne is much better than before but not quite cleared up, and then that's when I say, okay, now it's time to step up treatment and let's try the isotretinoin.
Right. But in certain ladies, I know there's quite, because of the fear of isotretinoids, they want oral contraceptives to be considered. Your approach to that? If it's grade 3, for example, and not the nodular one where you've already indicated that there's standard treatment.
So the thing about oral contraceptives is it is one of the treatment modalities that are available to us in females, and usually, so it doesn't work overnight, of course, as any medication wouldn't, and it usually takes about a month, for you to actually start seeing a difference, and I'm not saying a significant difference, but just even a slight improvement. And it's patients that, I sit down and I have a thorough consultation with, so I find out what their menstrual cycles are like. And it's usually the patients that have more hormonal acne. So that is acne that affects the U-zone of the face. That's the jawline and the chin. And it's females that have irregular menstrual cycles. And then, these are patients that would definitely benefit from the combined oral contraceptive pill. And that's for 2 reasons, for the menstrual cycle that's irregular or, not normal, and then of course the acne itself. Okay. So those patients definitely benefit.
And for how long would you treat them? And is the response rate as good as you've mentioned on antibiotics?
Sure. So at least 6 months, and obviously depending on how long the patient wants to continue. We have patients that are on it for years and they have no issues whatsoever.
Okay, but now I'm referring to purely using it for treatment. Okay. Is the cure rate as good, close to 90% after 6 months of treatment, for example? Or does it recur after the...
It does recur. Once you stop the pill, it does recur in a lot of the patients.
Okay, so it's not a complete treatment, it's a
more to control the acne,
okay.
Yes.
So
yes.
If they decide they want really to be cured of the acne, what would your advice to them be? If it's grade 2, probably say...
So unfortunately there is no cure for acne to date. Even, I just want to mention that, even isotretinoin is not a cure for acne. which is why I emphasize to patients that it's definitely the best. It's the best drug. We have a lot of faith in isotretinoin, but there is no cure for acne. No dermatologist on the planet can tell you that I have a cure for acne. Unfortunately, it's one of these chronic conditions. We hope that it only affects patients during their adolescence, but as I said, 1 in 3 women in their 30s are affected and 1 in 5 men in their 30s. So it can be recurring and it can come back later on, but there is no cure for it.
Okay, so now we're going to do what you call the gold standard. I mean, everyone knows it as Accutane and so forth.
Yes.
I have seen it available online without a prescription. I know of some of my patients who actually started using it before seeing a doctor.
Sure.
And it is really becoming problematic. But before we start, I'll talk about using it for treatment of acne. Just explain your approach to someone who you are even thinking of putting on Accutane.
Sure.
Why, or what you advise him, what's your discussion with him? And obviously, what I'm alluding to, what are the dangers of Accutane?
Sure. So Accutane or isotretinoin, that's the name of the drug, and then obviously you have lots of generics, Accutane being one, Acnitane, Orotane, there are so many on the market, but isotretinoin is not a drug that we take lightly, of course, and as you said that it's got a lot of side effects. So I normally sit the patient down, and the indications for using isotretinoin are obviously severe acne, so that's grade 4, nodulocystic acne or acne conglobata or acne fulminans, of course. And then, you have to, and of course, the other indication that often makes, dermatologists lean towards using isotretinoin is if they see any form of scarring on the patient. Because remember, scarring is something that's, it's irreversible and it's much more costly to treat afterwards in the long run. And the longer you leave inflammation and you don't manage it appropriately earlier on, the chances of permanent scarring are much greater later on. So that's the other indication. And then what I normally advise them is about the baseline bloods that we need to do. So if it's a female patient, of course she needs a pregnancy test, and that's because the drug is teratogenic. And by teratogenic I mean that should it will cross the placenta. Should she fall pregnant, it can reach the baby's blood circulation and it can cause severe birth defects in the baby.
Such as?
So we call it retinoid embryopathy. So it can cause neural tube defects, it can cause mental retardation, IQ problems later on. So we definitely do not, we emphasize this on day 0 that you are not allowed to fall pregnant. So I obviously ask them if they are planning, and if they're not planning, then obviously the discussion continues. And then the other side effects, and the most common ones are, so it causes dry skin and mucous membranes, because what it's actually doing is it's shrinking down your oil glands. And then patients often complain of mild headaches when they start, and that's because it's got a high vitamin A content, and we know that that can increase your intracranial pressure. So that's the pressure inside your skull. And even patients who are previously on doxycycline, they've come back to you 3 months later and they haven't cleared, or their acne hasn't cleared, and you now want to put on isotretinoin. We usually have a washout period, and by that I mean we give them a 2-week break so that the doxycycline is out of the system, and then we start the isotretinoin. And that's because doxycycline also raises your intracranial pressure. So we don't want the two,
together.
Yes, together.
Right.
And then I, of course, tell them that, they have to follow a low-fat, healthy diet, and that's because Accutane or isotretinoin can raise your liver transaminases, so your ALT and your AST, and then it can also raise your cholesterol, specifically your triglycerides, and then can also cause patients to be tired, can feel a bit fatigued, especially in that first month of treatment. So those are more or less the side effects. Yeah.
Do you sign a contract with your patients?
Yes.
Why?
And that is because often, things can happen. So with our female patients and our male patients, so what I do is I send them for baseline blood tests. That's the first time I've seen them. I make sure that all the blood results have come back normal, and then we commence with the isotretinoin treatment. And before they leave my practice, they get a form from the receptionist, and it's a contract that they have to sign to say that I've informed them about all the side effects, particularly the fact that they're not allowed to fall pregnant due to the teratogenicity of the drug, and male patients are also not allowed to conceive or get anyone pregnant.
Why?
And that's because it affects the morphology of their sperm.
Right.
Okay.
So in other words, it can cause birth, even if the partner, the female partner of the male patient is not on the isotretinoids, she can still get birth defects because of the sperm that the treated patient, the male patient has.
So it's a lower risk than the female, but it's still present, and it's our duty to inform them.
Right.
Yes.
So both of them cannot, the lady cannot conceive, and the male cannot cause someone to to conceive. So that's a bottom line with anyone who's going onto these drugs.
Yes, and that's why it makes me a bit anxious that you said that it's available online, because
no, absolutely.
Yeah, because it shouldn't be a drug that you should be taking over the counter. I mean, there are devastating consequences, should you fall pregnant. In fact, we tell females they're not allowed to fall pregnant for the duration of the treatment, plus for 2 months after you've stopped treatment.
And a lady, for example, who's sexually active, married one, or what would you advise her then? Does she just continue a normal birth control, or does she take additional
So we usually advise 2 forms of contraception. So suppose she's taking the oral contraceptive pill, and then we usually advise barrier contraception also with it.
In addition to that?
Yes.
Okay, I just wanted to make
just to be more safe.
No, absolutely. So but this, in medicine, everything is a risk balance and benefit ratio type of thing. So clearly the benefit of using the drugs, despite all the potential side effects, outweighs the risks.
Yes.
If we talk about using it, how long do you have to use it, and what's the success rates of it?
Sure. So usually treatment is about 6 to 9 months. And so the latest guidelines say that you actually treat the patient until the acne clears. And once the acne is clear, you still treat them for an additional 1 month after clearance. And then you stop the Roaccutane and you put them on maintenance treatment.
And what is maintenance treatment?
And maintenance treatment is topical retinoid, and that's for about 6 months after you've stopped the Roaccutane, just to keep the acne away.
Okay. And if you get good response, and of course here it will be the dermatologist or the doctor who decides as to whether it's controlled and not the patient. If the patient wants to continue because they're scared it might come back, how do you approach that?
So we usually do a low dose regimen, whereas they can take a very low dose daily. So I'm speaking about 10 milligrams, 20 milligrams daily. Alternatively, they can do, twice or thrice a week, also low dose, or just once a week. So there are different regimens that dermatologists adopt, just depending on the patient.
Okay. So if someone's been treated, for example, for 9 months, the acne is controlled, but then a few months later they get a flare-up.
Yes.
Do you restart the medication, or what would be the approach?
So a few months later, it wouldn't be ideal to restart the medication. Ideally, after that 9 months of treatment, let's say 9 months would have been the full treatment, 1 more month for post-clearance, and then ideally this patient should be on maintenance treatment for 6 months. But if it's flaring up even on maintenance treatment, then we should try and get them on optimal topical treatment, address any other potential triggers that could be making the acne worse. But it wouldn't be ideal to use Roaccutane for so long and then restart it within a span of a few months.
Okay. Are there occasions where you actually restarted?
Yes,
Okay.
I currently have a lot of patients that we've had to restart.
The control rate, let's look at numbers now. So what's the percentage of people after a full 9 months who are relatively well controlled and can use topicals only after the 9 months? Only?
I wouldn't be able to put it in numbers, but it's excellent response.
Right. And the recurrence months later or years later?
So recurrence is usually, it's male adolescent patients. It's patients that have truncal acne. By that I mean it's the stubborn, acne lesions that they have on the chest and the back. Those are the ones that tend to have recurrence. Usually patients with facial acne, they hardly have recurrence.
Okay, now if it's a youngster who you see for the first time, bad nodular acne, clearly there's a big chance of him developing scarring. So would you mention that to him, that it's best to start with the medication instead of going through the normal regime? Straight away.
Definitely straight away. I would definitely encourage him, and then what I normally tell them is, let's finish your course of Roaccutane, put you on 6 months of maintenance treatment afterwards, and then we address the scarring. And there are, of course, modalities for treating the scarring, but we never treat or address the scarring whilst there's active inflammation or acne lesions going on.
And to end off scarring, how would you approach that?
Sure. So there are different types of scarring that acne vulgaris can cause, and the common ones that we see are atrophic or hypertrophic, and hypertrophic are those, thick indurated scars, almost keloidal scars. And then the atrophic ones are the more, where skin has been stretched. It's more, and you get different types of atrophic ones. So you get the ice pick ones, which are the pinpoint ones that you see on the cheeks. You get the box scar ones, the rolled out scars. So there are several modalities that we use. And of course, it depends on the patient and, their budget as well. And we usually use resurfacing treatments, and that can involve microneedling, microdermabrasion, chemical peels, and then laser, of course, is a very important modality that we use.
Okay, in fact, that's a topic that we should really address one day. In fact, we're seeing more and more GPs doing these type of procedures, doing Botox, for example. It's always good to get a dermatologist's opinion about that. But I think we've done, you've really been enlightening as far as acne is concerned. I think we've covered most of the common questions that patients always ask us. Anything else you want to add before we close up as far as acne is concerned?
I think the most important thing is to remember that it's, you don't want to over cleanse your skin, because I get a lot of patients at practice who think that, greasy skin means that the skin is dirty. And you can have oily skin and still have skin that's dehydrated. So don't forget that you can cleanse once or twice a day. Don't forget to use a daily moisturizer, because many don't know that your skin barrier in acne is impaired, just like it is in rosacea, for example, or eczema. So you want to moisturize and maintain that skin barrier.
Even if it feels oily?
Even if you have oily skin. Okay. But then get a water-based moisturizer.
All right.
Okay. And greasy on grease. So no occlusive products, no oils, please, that are going to aggravate the acne. And then I would say that definitely sunscreen is another important addition to your skincare routine, even if you've got acne. And I mean, there are wonderful hypoallergenic, non-comedogenic, so non-blackhead or whitehead forming sunscreens out there that you can use on a daily basis that won't aggravate your acne, and especially with summer around the corner.
I think we need to chat about summer being around the corner. It's going to be beach days, sun exposure. Yes. So inshallah, in the next program, we should address that.
Yes.
Maybe if it's possible, we bring some of the recommended sunscreens along, without obviously...
We can show them.
Without actually showing a specific product, because we don't want to be promoting a specific name.
Sure.
But I think that will be a good idea for us to
educate
our sunbathers, who's going to be pretty soon in coming with the summer season, inshallah.
And then just the last thing is don't wait. Rather treat it earlier than later. I mean, don't let the inflammation persist and then result in significant scarring afterwards. Get it sorted nice and early, because it can really have psychosocial repercussions. I mean, I get patients with anxiety disorders, depression, even social withdrawal because of the acne. So really, you have to nip it in the bud early.
Okay, you've mentioned the fact that there's such a lot of psychosocial issues. The first port of call is normally to a doctor, a GP like myself. Do you think there is a lag period that the doctors refer? Do you think we should be doing it in a quicker time?
I don't think so, hey, to be very honest. I mean, I've had a lot of GP referrals for acne. In fact, I've had grade 1s and 2 acne also coming my way. So I don't think there's a lag period. I think just patients or maybe family members don't perceive it to be that great a problem. And I think probably the lag is at home, not with, I mean, GPs.
With referrals.
With referrals.
Okay. Shukran for that positive feedback to us. But thank you once again. It was, I mean, time just flew. I mean, I didn't realize we over time already.
Fun,
yes,
why.
Absolutely. We're going to have more fun in the sun, but for that, we're going to prepare our listeners and our viewers in probably about a month's time, inshallah. So we welcome you back and we'll continue this program. Shukran for listening and watching the program. I hope you found it all interesting. To you, Assalamu alaikum wa rahmatullahi wa barakatuh, and to the viewers, Assalamu alaikum wa rahmatullahi wa barakatuh.
Through knowledge for all.